Good afternoon and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Welcome. Glad you could join me either live or delayed. I guarantee you this is live because our guest, Dr. Chaplin, is having some technical issues and a few offices down from me getting on. So hopefully we'll get him online here shortly. My plan was to do Dr. Chaplin and talk about regional nerve blocks and anesthesia, and then do a COVID update. I think we're going to flip it up. We're going to do a COVID update first. So I think Matt will show you a chart. This is the one we always show. And yeah, it's looking pretty similar to what's looked before, maybe just a slight little uptick in cases, but all in all, pretty good. So I think that's encouraging. I saw today, thanks, Matt. I saw today too that, oh, hey, I see we have Dr. Chaplin. I tell you what, I think I'm just going to keep going, Matt, and then we'll have Dr. Chaplin pop on once I'm done with this, okay? As always, if you have questions, send them my way as we're doing our thing, okay? So, Illinois Hospital Association, my daily update yesterday, there were 546 patients in the state of Illinois hospitalized with COVID. I think we got down in the upper 400s last week. So it's fluxing up just a little bit, but that's still compared to where we were at 4,400 recently. That's way better. Here at the hospital, numbers continue to look good in terms of the number of patients with COVID compared to the surges we've had in the past. So we're glad to see that. As all of you know, there's a new variant in town called BA.2. It's a variant of Omicron. It's causing, I'm reading anywhere between over half to 72% of the cases in the US right now. Oh, fun fact, there's another variant called XE that's kind of coming around. I forget, maybe it was in the UK. I can't remember where it was at, which had, oh, by the way, 10% increased transmissibility compared to the BA.2. So more to come on that. Mayo Clinic, pretty smart people, have predicted in the next 2 weeks a 64% increase in cases. I know that sounds mean and nasty, but keep in mind that that's going from 22,748 cases a day, new cases a day, to 37,419. Math on that is about 1 in 10,000 of us will get infected per day once we go up in the next 2 weeks here. So 1 in 10,000 per day is still not a lot of cases compared to where we were at where we've been at in the past. And as I mentioned before, the prediction is actually the hospitalizations will not go up despite the increased number of cases. As a matter of fact, that Mayo Clinic says that they think the hospitalizations will actually go down, probably because this BA.2 appears to be a milder form of disease in general than some of the other variants. I saw a really interesting article today that I would encourage you to take a read, and I've begun to see it in some other places. I think it's getting shared on, like the Googles of the world kind of sites. It's a New York Times article from today, and the article is entitled, "Is This What Endemic Looks Like?" And I'm kind of going to regurgitate a few facts from that I thought were really interesting. So first of all, they were just kind of giving some facts that endemics can be mild or deadly. So colds are endemic amongst we humans and not deadly. It does kill a few thousand a year, but not deadly. Malaria, endemic, it kills, the numbers are around 600,000 in the world a year. So they can have periods where we're endemic, and then they become more pandemic. Think flu season, where it's endemic throughout the world, but it tends to have a cold season flare, if you will. The burden of the endemic disease can be unequal. So if you have access to vaccines, if you have access to really good treatments, if you have really good health care, your opportunity to bear through the storm of an endemic are much better than places in the world that don't have that. It also becomes all about just managing a disease that can't be stopped. So once again, testing, treatments, vaccinations. Those are the things that help to keep endemics at bay. And the final thing that I thought was really enlightening was, when will we know that COVID is in its endemic phase? And the answer is it could be years. And the example they gave was the flu of 1918. It's the mother of all pandemics, at least in our modern time, which killed upwards of 50 million people. And I think that might have been, I'm not going to say if whether it was the world or US, but 50 million people, a lot of people. I think it was worldwide. Anyhow, from the time it hit in 1918, there were surges of pandemic related to that you can see on a chart until the 1940s, and really it became really endemic in the 1940s plus. So that was like a 20-year window or 20+ year window of that. So it's going to take some time. It's not like we can just say today, oh, yep, we're an endemic. It takes some time to sort all that out. So I thought that was interesting. I encourage you to give it a read. As you know, the 50+ booster shot has been approved. We know it's unlikely to harm you if you get that booster shot. The odds of having a reaction are very, very, very low. What would I suggest? If you're over the age of 65, yep, I think I'd get one. If I was over the age of 50 and I had a high risk factor for getting really sick, I think I'd get one. If you're anybody else, I'm not sure. I don't think anyone is really, as far as that goes. But that's kind of how I'm looking at it right now. The other thing that's trying to get sorted out, as you read across the news that I see and then medical news, is trying to figure out a long-term vaccination strategy and what that's going to look like. So the goals of a long-term strategy are going to fall along the lines of preventing severe disease, trying to figure out what criteria to use to update vaccines. So in other words, to give you an example, they're talking that if we want fall booster shots, let's say for COVID, the decision to what to put in them, what kind of variants to cover, that needs to be made in May, which, as you all know, is not that far away. So it gets really sticky trying to get that all figured out in terms of what to put in there. As we know, new variants are still popping up. So it is a ticklish situation to try to figure that out. But people way smarter than me are on that and working that through. Will it be perfect? I doubt it. The flu vaccine is not perfect. But I do think there will be opportunities to I think it's likely there'll be opportunities to get boosted in some way, shape, or form that'll help us from getting hospitalized and really sick from COVID in the future. And also part of that long-term vaccination strategy is to be able to have the ability to collect data and see how effective the vaccines are, and then continue to modify in subsequent boosters. So that's enough COVID for the day, but I thought those were at least interesting enough facts that I would share with you. Appreciate you hanging in with me to listen to those, but I think they're helpful pieces of information. Okay, let's get Dr. Chaplin on, Matt. There he is.
Made it.
Hi, Dr. Chaplin.
How are you?
I'm doing well. Good to have you. I'm glad we worked through our technical glitches and got you here online. So Dr. Chaplin is an anesthesiologist here at CGH, and his team is doing some really exciting stuff to help our patients for some of the surgeries that we do here at CGH. And I thought this would be a great opportunity, a great venue to educate and inform you about what we're doing in the anesthesia world to help our patients. So Dr. Chaplin, are you ready to go through a few questions?
Yeah, let's do it.
All right. So we're going to talk about, do you call them regional nerve blocks? Is that what you're calling these days?
Yeah, so I mean, any regional anesthesia, which is, encompasses both neuraxial, which would be like a spinal block, or an epidural would fall kind of in there.
Yeah. And
then also all of the peripheral nerve blocks that we do, which is peripheral meaning somewhere outside of the spine, pretty much. So which all fall under the regional anesthesia kind of umbrella heading, if you will.
Yeah. So let me ask you this. So what's the advantage of doing these kind of nerve blocks? And it seems to me like we're doing more of those now than I remember when I was a kid, when I was going through medical school and residency and training. What are your thoughts on that, Dr. Chaplin?
Yeah, now regional anesthesia has been around for decades, but probably within the last 10 to 15 years, with the inclusion of ultrasound guided regional blocks, has really changed the game. If you look back at kind of the history of anesthesia, there's kind of those game changing events, and ultrasound guided blocks is one of those game changers, really, because what it did is it allowed us to be able to do these blocks to specifically target nerves, to be able to see where we're putting the medicine, and be able to do them a lot safer, decrease the complication rate by like about 2 factors of 10. Typically, and really makes life a lot better. So why we would do these blocks?
Yeah.
Number one, and probably the best thing for the patient is post-operative pain control.
Okay.
So we can allow these blocks to last for quite a bit of time, to get them through different surgeries, to allow to give us a non-pain medicine, a non-narcotic way of controlling pain. If we just interrupt the sequence from the pain nerve where you can go into the brain, then the brain never understands that it's actually feeling any pain at all.
Yeah.
So it's a very safe way of treating pain in a non-narcotic, non-opiate type of way. It also helps us during surgeries. It allows us to do surgery sometimes on patients that are otherwise maybe not healthy enough, or that their risk factors would be higher if we were to do general anesthesia with them. Unfortunately, there's still some risk to doing those things. So sometimes these techniques allow us to be able to take less healthy or patients that that have a lot of other comorbidities or things going on in their life, that we can still take them to surgery and still fix things for them. But we just do them under a block, and then sometimes with sedation rather than full general anesthesia.
Yeah, that makes sense. So let me ask you this too. So where does CGH fall in the curve of doing these ultrasound guided selective nerve blocks? In other words, like if you were to go to a typical community hospital, where are we at in terms of the ability to do that versus others?
Sure. So I think that we're doing pretty much anything that's being done in the mainstream of anesthesia right now. So I won't necessarily say we're on the cutting edge, but we're picking up the newest of the new techniques, and incorporating those into our practice. Definitely things that maybe not being done at other facilities. And to no fault of anybody coming out of training, but exactly kind of what you said there, Dr. Bird, it's only been in the last 10 years or so of really in training where regional anesthesia has become a much larger piece to that. So there's a very large generation of anesthesiologists that just unfortunately didn't get this type of training coming out of residency. And so unless they've taken time, which is always possible, to learn it post residency, it's not as familiar to some people.
Right.
Something that is heavy in my residency program that we did and in my training, while at the same time we have a really good group of CRNAs, nurse anesthetists, that are all very very good with ultrasound skills and very adept at doing these blocks as well.
Yeah. As a matter of fact, I don't know how you feel about this, Dr. Chaplin, but I mean, if I was going to have a surgery that potentially could have a regional nerve block, one of my questions would be, do you do that at the place I'm going to have my surgery? Because in terms of the pain control and being able to go at it in terms of physical therapy afterwards, I think that's really important.
Absolutely. Yeah, there's a lot of good data coming out that we have better pain control, less opioid consumption post-operatively, less days in the hospital, on some of these different types. And a lot of that data is coming out of like total joint arthroplasties for total knees and total hips, particularly total knees. So it gets you out of the hospital faster, gets you up and walking quicker, better recovery with physical therapy. And it's kind of just a win-win-win situation all the way around.
Yeah. Okay. I agree with you wholeheartedly, Julie. We do have a top-notch anesthesia team. Okay, Mary's asking, how long does anesthesia stay in your body? What would you say about that?
Sure. So good question. It's going to be dependent upon what type of anesthesia we give you. Um, the kind of old dogma of thought is that general anesthesia will say it's our fault for the first 24 hours. Meaning, let's say there's a post-operative fever or something, we can usually sometimes attribute that to the anesthetic within 24 hours. So that way,
This is for general anesthesia, right?
right, for general anesthesia. Typically, though, patients will wake up and may feel, kind of groggy and a little out of it for a while, and it also is highly dependent upon the patient going in. The more cognitive dysfunction that's there, the dementia or delirium that's there preoperatively, the higher the likely chance that they're going to continue to have that postoperatively, and that can sometimes stick around for hours to even days. But in a typically healthy, otherwise, well-functioning brain, most of the time, you wake up from a general anesthetic within 20 to 30 minutes and pretty much have your faculties about you. Regional anesthesia is highly dependent upon what we inject. We have some different medicines that we can use that we can hopefully make these blocks last for 2 to 3 days. So 48 to 72 hours is what we like to kind of tell patients. That being said, I've had blocks last a lot longer. I've had them last for 4 or 5 days. I've also had the blocks last for less. There's a large piece to that has to do with how fast your body metabolizes that medicine.
Okay.
Without having a really expensive and sophisticated genetic testing beforehand, it's kind of hard to predict those things.
Yeah.
And then it also comes down to our technique and how much we inject and how close to a nerve and different things like that. So
yeah, thank you. So one of the things you started talking about was total knees or knee replacement surgery. So let's talk about that and the anesthesia in terms of the local anesthesia, the selective nerve anesthesia. So questions for you are, what nerves are targeted? When is this done? How is this done? Is it painful to have done? And what will patients notice when they wake up from surgery?
sure.
Yeah, and maybe just even thrown in. Well, you kind of mentioned some of these patients will need general anesthesia and some won't, right? So I'll let you I threw a lot of questions at you, Dr.
So
Chaplin. I'll let you go ahead.
let's take a total knee arthroplasty or getting a new knee because that's a common thing that we see. So typically for that, we're going to do what's called an adductor canal block. And Matt, if you can bring up that first slide here too. So this is an animated version here of your leg, and one of the major nerves that comes down from your groin, and there's a branch of this femoral nerve that's called your saphenous nerve. So this is the nerve that we're basically trying to target and block here when we do what's called an adductor canal block. So I always tell patients about midway up your thigh, just to the inside or medial side, is where we're going to place our ultrasound probe. We're going to identify the anatomy and then inject numbing medicine around that nerve that you can kind of see there in the yellow. If we can go to the second slide here, Matt. This is an ultrasound image of what we'll actually see when we're doing this block. Up here at the top, you'll see kind of the subcutaneous and skin and fat layers. Right underneath that, you'll see that big muscle it's labeled the sartorius muscle, and that's one of the big muscles in your leg. And right underneath that, you'll see the femoral artery that's highlighted there. And then just to the right side of that, where the arrow is pointing to the saphenous nerve, that's what we're targeting, basically.
Okay.
Don't see an actual needle here. That blue line would represent where the needle would come. We would get right down next to that nerve and inject medicine around there, and it should hopefully spread around that nerve and give us some pretty good pain relief.
That is amazing. I mean, I don't know if folks understand how if you think about 20 years ago, what they just couldn't do that because of the visualization that you have there to be able to do that.
The beautiful thing about an adductor canal block and why it has replaced a femoral nerve block, which would be the same nerve but much higher up before it branches off, is it spares motor weakness, meaning that the large muscles of your leg will have already received their innervation, and so they typically don't get weak. You don't get quad weakness at all. So you're able to get up and work with physical therapy. So you asked what will patients feel? Sometimes when we do that block preoperatively, they may not feel anything. And I always tell them that doesn't mean that it's not working. Now, if they have a lot of pain in their knee already, it may start to ease off a little bit. It typically takes about 20 or so minutes for the block to fully set up. And so a lot of times before we take them back to surgery, we may start to feel a little bit of decreased pain, but maybe not, and that's okay. You asked when we typically do these. A lot of times we do these right immediately before the surgery starts. Here at CGH, we typically will do them out in our ambulatory surgery unit, or ASU. So in the room that they check in at, basically when they're starting your IVs and things like that. Immediately before the procedure, we talk about the block and what we're going to do. We clean the area off so that we reduce infection. And then we use a special needle that shows up really well on the ultrasound screen in order to do that. It's a smaller or less thick needle than what they typically use to start your IV. Okay. So you asked about how painful is it? It's like getting an injection. It's not pain-free, but it's typically pretty well tolerated by most patients. If there's any concerns about that, then we'll give a little bit of sedation in ASU. We just have to make sure that we have all of our consents and things signed.
Sure. Yeah, right.
To speak to your surgeon before that, because that medicine can make you a little groggy. So sometimes we'll go ahead and sedate patients up as well and make them a little bit more comfortable. But for the most part, patients tolerate these blocks very well, and particularly the adductor canal block. It's a very not a super sensitive area that we're injecting in.
Yeah. Awesome. Now let's talk about hips, and essentially my question is basically a rinse, cycle, repeat question. Mm-hmm. Same questions I ask you for the knee, Billy. I'm gonna have you knock them off for what that means for hip surgery.
Sure. So hip surgery, total hip arthroplasties has kind of been an area that's always been difficult for pain control and anesthesia. Targeting those nerves becomes very difficult. But about 2018, 2019, there was a group of anesthesiologist docs that got together, and they came up with they theorized a new way of doing a block and kind of created, they described what's called a PENG block, or PENG, stands for pericapsular nerve group. We went ahead and we've adopted this into our practice here for total hips, for hip fractures, for hemi-hip arthroplasties, sometimes for broken legs, broken femurs. And we're getting excellent results with this. Okay. This is an animated picture here, thank you, Matt, that we put up of your hip joint. On the right-hand side, you can kind of see where the ultrasound would be placed. That's a patient's leg, and you can kind of see what's called the ASIS, or the anterior superior iliac spine there just right of the probe. Right underneath on this animated piece here, right underneath that big white kind of circle in the center, that's your psoas tendon. We try to get down right underneath the psoas tendon and inject medicine underneath that plane, and it spreads throughout this kind of muscular plane right above the bone. And in this animated series here, you can see the kind of small little nerves as they come down. And these are the nerves that go into your hip capsule and innervate the actual hip joint itself. So what we're trying to do here is, instead of targeting one specific nerve, we're injecting, it's kind of what we call a fascial plane block, where we're just injecting medicine underneath a muscle or a fascial layer, and it spreads out and covers multiple different nerves. But we're catching all the nerves as they come into the hip joint, and it causes really good pain relief. We've had a lot of patients who will do this for a hip fracture. Sometimes if they show up in the emergency department, we may get called to come down and help do this, or out on the floor even. And by the time we're done doing the block, they're pretty much pain-free and thinking they can get up and leave. And no, we still need to fix a fracture yet. But it can be pretty profound, the amount of pain relief that patients get from this. We've been doing this PENG block now for probably about 6 months or so, a little bit longer than that. and I've been having really, really good results. So when you spoke to kind of where we're at with, compared to other hospitals, this is a technique that that I didn't pick up in residency. I picked this up after residency just here with another one of our CRNAs that said, "Hey, I think we should maybe give this a go," and we all learned it and have now been doing this. So again, we continually educate and trying to stay, like you said, on the cutting edge a little bit here. I think that this is a nerve block that's going to become very commonplace, and within 5 years probably will be being done most places. But right now, this is still this is pretty brand new stuff here. This is within 3 years, and that's, in our world, that's brand new.
Right. Yeah. So once again, I mean, this is one of those things where if I'm getting a hip replaced, I want that because it allows me to not have the pain after the surgery. It allows me to do physical therapy right away because I don't have the pain that you typically would have with that.
And the beautiful thing again on this block, just like that adductor canal block, it's primarily a sensatory block only. So it's only going to numb the sensation, and not the muscle strength. So patients are still able to walk as early as, usually we have patients working with physical therapy later in the afternoon on their first day of you receiving a new joint. So this doesn't block that. There's always a risk factor. In that image, you can see that the femoral nerve runs pretty close. So some of the medicine can always travel up that way. We try not to have that happen. If that was, then we may see, some leg weakness. And that's our goal, is for that not to be done. And that's where ultrasound guidance comes in so heavily, because we're watching the medicine spread and it's going exactly where we want it to go and not going somewhere we don't want it to go.
Yeah. That's just so cool. All right. So let's move on to other extremities. So let's talk about shoulders, arm, wrist, elbows, all that kind of stuff.
Awesome.
What type of nerve blocks are you doing for patients for basically shoulder on down?
Yeah.
Can you talk about that, if you would, Dr. Chaplin?
Yeah. Matt, can you bring up the fifth image there? This is going to be an image here of what's called the brachial plexus. These are all the nerves that come off of your neck and they innervate your entire arm. So they travel from down past your shoulder, elbow, wrist, fingers. Different types of blocks for different types of surgery in the upper extremity, but primarily highlighting a couple of them. We do what's called an interscalene block, where we're blocking the nerves in between these two anterior and middle scalene muscles. And Matt, can you fast forward into the next one, please? This is an ultrasound image of what we'll see, and it may look kind of like a bunch of circles and grains of sand, but to me, this is a beautiful image of the interscalene nerve block. On the right-hand side, AS standing for anterior scalene, MS standing for middle scalene, and then in between there, labeled C5, 6, and 7, are going to be three large nerves. We call that the traffic light appearance because they kind of stack up.
Okay,
At least in the textbooks, they stack up. In real life, not always every time.
Yeah.
We would inject medicine around those nerves to cause pretty profound numbness and loss of motor control to the whole arm. So this is a block that affects both sensory and motor.
Okay.
So when we do these types of blocks, patients are in slings afterwards. Most of the time after rotator cuff repair, surgery, patients are going to be in a sling anyway. So you're not really noticing any difference. It can cause, again, we usually will block this up for 2 or 3 days. So you may not have very much use of your arm for that period of time, but it's really good pain control.
Yeah.
You may not be 100% pain controlled, depending especially on where else any of our surgeons needed to work. And everybody's anatomy is a little different. Everybody has, feeder nerves from different places. And so we try to get as much pain control as possible. This is a type of block, though, that would work for shoulder surgery. We could do this for hand surgery and elbow surgery. Although we may go down slightly, I don't have a picture of it, and do what's called the supraclavicular block. So instead of blocking here, kind of on the side of your neck, we would come down just above your clavicle and inject medicine around those. And that allows us to target some other nerves, particularly the ulnar nerve, which would be like your pinky and kind of the inside of your elbow here. So if we're doing surgery here on your elbow, a lot of times we'll block it there, or we may do what called an axillary block, and where we can find those individual nerves here on your underarm, and we inject medicine there instead. And that works very well also.
Good. Okay. And then the final block I want to talk about today is something, I think you told me it was a TAP block. So tell our listeners what that is and what that does to help patients out.
Sure. So we've been talking a lot about extremities, and a lot of these nerve blocks are done for orthopedic, for podiatry surgery. But for some of our general surgeries as well, we can do what's called a TAP block, or transverse abdominis plane is what that stands for. Matt, can you bring up the seventh image, the last one there? So this is actually an image of the three layers of your abdominal muscles, your external, internal, and then the transverse layers there. In between the second and third layer, in between the internal and the transverse, is where all the nerves run from your spine, from the spinal nerves as they come across, and they innervate the skin and the front of your belly. So for large open belly cases, we can, to cover the skin incision kind of pain, we can do what's called a TAP block. We'll do this one on the right and one on the left, where we inject medicine in between those two layers, and it hopefully covers a lot of that incisional pain. What that allows us to do is when patients wake up, depending on what type of surgery, they may still have pain kind of on the inside from the organs, because this doesn't cover visceral pain or organ pain. But a lot of times that incision will be one of the most painful pieces of recovery.
Right.
And so this would help block that discomfort, which can allow patients to breathe a little bit easier, breathe deeper, to get off of oxygen, to really kind of help them out post-operatively. So we'll very frequently do this procedure, or do this at the end of an operation while the patient's still sleeping under general anesthesia, and we're able to get a little bit better pain control for our patients as well.
Yeah. You do that at one level or multiple levels?
We typically, for this type of a block, we do it at one spot, because the medicine will use a high enough volume of medicine that it'll open up, and what we call hydrodissect, where basically the medicine will kind of open the area up and spread in enough, across enough region to cover enough.
Yeah, it spreads across that plane well enough that it covers a lot of.
Exactly. It covers it high and low enough to be able to do that. Sometimes if the incision is large enough, it may miss a little high, it may miss a little low. And that's where we kind of have to, there have been times where we went in and then reblocked a little bit, moved lower if there's pain somewhere. So
okay, very good. So in terms of pain, the other question I want to throw out at you is, we're talking mainly about these nerve blocks, but I wanted to ask too, what other ways does anesthesia work with our surgeons to help to control patients' pain without having to use narcotics?
Sure.
I wanted to just kind of give you an opportunity to talk about that too before we concluded.
Yeah. Regional anesthesia is a huge piece to that. And again, the other piece that we didn't really talk about again was neuraxial blocks. And so doing spinal anesthetics.
Okay. Yeah, sure.
And even sometimes we can put a little bit of very small amount of pain medicine in there, and it will last for 24 hours. And so you can get really good pain relief. It's what we do for C-sections and even some of our hernia repairs and hysterectomy cases. We try to maximize our non-narcotic options. We're really blessed here at CGH to have a lot of different options when it comes to that. It was something that actually attracted me to CGH when I was interviewing, was that was able to see how open we're able to get certain types of medicines. That's not the case at a lot of places. I have access to IV Tylenol, and I don't really have to bend anybody's arm to give that to people. And that's not the same as it was anywhere else I've ever seen. We do a lot of Tylenol, a lot of Toradol, which Toradol is a very good, it's an ibuprofen. It's an IV form of an NSAID. We will use other types of medicines also that are classified as anesthetics, that will that added to their general anesthesia can target other pain receptors, and pain's a fascinating subject, because it's not just one type of receptor that causes pain. There's dozens of different types of receptors that are on there. Your main ones being some of your, opioid receptors, and that's why narcotic pain meds are so widely used. But that's just one type of receptor that can cause pain. So some of our other anesthetics that we use during cases, whether that be things like Precedex, ketamine, and other meds, propofol, those can all help dampen post-operative pain responses and treat pain in non-narcotic ways. So we try to do quite a bit of that, and we're incorporating more and more of that into our typical standard approach every day, I feel like.
Yeah. Very good information, Dr. Chaplin. Hey, I wanted to give you an opportunity to give any shout outs to your team if you.
Sure. No, I mean, the whole team of CRNAs, we have an excellent, very, very good team of anesthesia here. Lynn is one of our CRNAs. So no, she's correct. We do have the best anesthesia team. Special shout out, to Xavier Marino, because Xavier, he's the CRNA that I was kind of alluded to here, that Xavier has some advanced training in pain management. And so some of these newer blocks, he's been really on the forefront of pushing us to accept those. And I've been absolutely, I love regional anesthesia, and I think we all do in our group. And so it's been something that we've really put to. But every one of the CRNAs has been integral into making, to turning our group into what it is right now.
Yeah, good. Well, for those of you who are watching, if you can't tell, Dr. Chaplin has it going on, and his team has it going on as well. They're excellent and do great work. We are so glad to have them here at CGH. I'm so glad that I had the opportunity to talk with you, Dr. Chaplin, and give you a chance to inform and educate folks about what you're doing to help patients during their time in the operating room and afterwards. So thank you so much for taking the time to be with me today.
No, thank you. So it was great.
Yeah, very good. Good. I'll let Dr. Chaplin go back to doing anesthesia. And thank you very much. Yeah. And so the only thing I wanted to say in conclusion is just, we do a couple other points is we do have a blood drive going on today here at the hospital. Matt's going to put something up about that. It's actually happening today, but I'm told there are still, as of the time I started doing this interview, 20 slots left, if I remember right. So there's still an opportunity to give blood if you are so inclined, and we hope that some of you listening will be so inclined. So yeah, that's where we're at today in terms of blood drive. Thanks, Matt. As for next week, as always, we'll give you an update of what we know, what's going on with COVID in the world and here in CGH as well. We also are going to be talking infection prevention. So talking about what we do here at CGH to prevent infections here at the hospital. Oh, Julie, okay. Hey, thanks. Very kind words. Thanks, Julie. And I couldn't agree with you more on all counts there. So yeah, I think I'm going to wrap this up. But as I said, as I was saying with Dr. Chaplin, they do just a fabulous job. And they do some stuff here that is really, I really think it's cutting. I know it's cutting edge. So great to have him on. And please feel free to share this with those who you think might be interested in knowing more about this, particularly folks who might be thinking about upcoming surgeries. So until next week, I thank you so much for taking the time to listen, and I hope you have a great week. Thanks.